Today's webinar is about 510K project management. I've recorded this webinar quite a few times, and the most recent time was last year, and it was an awesome webinar. I'm going to keep it up on our YouTube website because it included a lot of people from our team, and each person contributed quite a bit to the discussion. So I'll include that link below in the YouTube comments or details about this video. But this particular one, I'm making some slight adjustments on how I explain 510K project management. The reason why is in the past, all my training on how to manage a 510K is focused on the point at which we actually start preparing the 510K. But what ends up happening is companies engage our firm before that, and they need help with a testing plan. They need help with a pre-submission. And there are a lot of delays that occur up until the point we start preparing the 510K. And my hope with this video is that we can speed up the process and accelerate everything that leads up to us starting the preparation of the 510K. So about halfway through this video, I'm going to make it very clear. Okay, now we've passed the point where we're no longer doing a lot of the legwork and preparation to start our testing. Now we've started our testing for the verification and validation, and this is also the point at which we're going to start preparing the 510K. So there'd be a clear break in the middle, and really most of what we were teaching in the past was the second half of this video, and so a lot of this stuff is design controls, but it's very focused on what things do people typically not remember to do, or things that they're forgetting to do that would really help them speed up their 510K clearance process. So as we go through the slide deck, I'm going to share my screen for the PowerPoint presentation, and then I'm going to switch back to video or sharing my screen if I'm showing a browser window or something. And if you have any questions, please put them in the comments, or you can email me. My contact information is at the end of the slide deck. And also, don't forget, if you're still having any questions about this, we have a link at the very end for you to schedule meetings with me and ask additional questions. And if you get to find that this video is really helpful to you, hopefully you'll like it and share it with other people. Here we go. Okay. So this is the 510K project management presentation. And what's a little bit different here is that I've just kept this first slide, but I changed the date. But here's where we start getting different. Pretty much all the other slides have tweaked in some way and made improvements from the last time we did this. This was something that was sort of an add-on. Matthew Walker had created a training presentation for another group, and we thought this would be useful information. We included it in the presentation last time, but we didn't emphasize it since we published a blog on it. And when I look back on it, these 10 things are probably the bulk of the first half of this presentation. These are the things that are causing massive delays in most of our clients' submissions. They're not doing these 10 things. They spend a lot of time focusing, when can we submit? When can we submit? When can we submit? But these are the 10 things that are holding you back. So really take a look at each one of these. And I've emphasized the planning one with red. You really need to make sure that you plan your design project. And so we're going to go one step further. When you sign up so you can watch this on YouTube, but also there's a hyperlink below where you can actually register for this and download the actual slide deck. If you do that, you're also going to get two other documents. One is our design and risk management plan template. The other thing that you're going to receive is our actual table of contents that we use for managing a 510K. Now, you don't have to submit a 510K table of contents anymore if you're using an FDA eSTAR, but we'll talk about that later. These other documents are absolutely necessary. We have companies all the time that are doing electromedical devices, and they haven't worked on the risk management file. They don't realize that they're going to get an 80-something page document from the electrical safety lab asking them to please cross-reference where we can find the following information in your risk management file. And they don't even have a risk management file. They haven't even done any risk management activities. They don't have a risk management plan. And if you're trying to CE marking, you need a whole entire risk management file. So this is not a minor item. This is a major task that should take months. It's going to be multiple meetings. It's going to be multiple cross-functional people working on this. Risk management is not a small deal. Formative usability testing. All the time, people are telling me, well, we don't need to do that. We've provided a justification for that. And then the FDA kicks it back and says, no, this isn't acceptable. And they point out all the kinds of things that are wrong with their usability testing. You need to do formative usability testing. One of the reasons is to identify the use errors that you didn't identify by brainstorming or looking up in complaint records. There are other things that you will have missed, and they will show up in the summative testing, and you will fail your summative testing, and by default, your summative testing will become your formative testing. So then instead of spending $100,000 for your usability testing, you're going to spend $200,000 or $300,000 because you're going to do it twice. For the software validation in cybersecurity, any device that has software requires software validation, and you have to submit 11 documents to the FDA. They also want an off-the-shelf software documentation as well, and there's a guidance document for off-the-shelf software. And then they have 2 cybersecurity documents. One's from 2014, I think the other one's 2016, and talks about cybersecurity post-market surveillance. That software validation document is a massive amount of documentation. It's 11 different documents that you have to provide, plus the off-the-shelf, plus the 2 cybersecurity. You're going to have a 1,000-page submission. Oh, but it got worse. Now, the FDA has a 2022 guidance document that they're in the process of reviewing and approving with comments from people, and they're actually asking for testing on cybersecurity. So now you have to do vulnerability testing, robustness testing, boundary testing. You have to do penetration testing. They want it to be done by qualified individuals that are independent of your organization, and they want evidence of their qualifications and independence. Now you're going to add another 1,000 pages of documentation to the software section. So now it just became the biggest section in your entire submission. It was close. Now it definitely is. So if you have software as a medical device and you thought you were getting off easy, cybersecurity just made it a nightmare. If you think that's something you're going to do really quick at the end, you're mistaken. Supplier qualification. I can't tell you how many companies I work with that they build all their prototypes for testing from one vendor, and then they switch to another vendor, and they think, oh, well, it's the same specs, but the new supplier used a different process, so that changes the biocompatibility of that component because it's a different manufacturing process, so they have to repeat their biocompatibility. Or they have a different battery supplier, and the different battery is a different size, so it has a different footprint, so it has a different housing, and they have to redo all their electrical safety testing. These little tiny supplier qualification changes. So you went from one supplier to another supplier because the supplier that you use for prototyping won't make it for production, or you need to reduce costs. You need to think about these decisions earlier and qualify the production supplier earlier, get them to source components earlier, because otherwise you're going to repeat all your testing. The cost is not in the audit of the supplier. You could do a desktop audit. You could do a remote audit. The cost is in having to redo all your verification validation testing. You made a change. So pick wisely for suppliers and qualify them early and get them set up for you're being your commercial supplier, not just a prototype supplier. Labeling requirements and instruction for use. A lot of companies, we're waiting for this. This seems to be one of the last documents they give us. There's no reason for it. You should have a finalized labeling and instruction for use before you get to V&V testing. The reason why? You're going to have to do summative usability testing, and you should be developing the instruction for use during the formative testing. And so that way you go into the summative testing with your finalized instruction for use. One of the purposes of doing that formative testing is to help develop those instruction for use and debug them. So develop that early and have an ongoing draft that's finalized when you do your design freeze. Packaging specs, often an afterthought. But if you've never made a sterile product before and never validated sterilization before, you don't realize how big of an order you're going to have to place. A minimum order size for sterile packing is gigantic. It's usually 5,000 pieces, and you need what, 500 pieces? You're going to have to pay for all that packaging. You're going to have a long lead time for that packaging because you want it to be a specific size. And yes, you could use a little bit bigger size, but then it would fail your packaging validation, and you would have to redo all your testing when you change the different packaging requirements. So spec those packages earlier, get somebody professional, it's a professional packaging engineer involved in that, and have them help with you with your testing plan for the packaging and validate that. So the package that you did all your verification and validation on is the final package. Yes, you need a quality system. That's not an afterthought either. You should have design controls, risk management, software validation, and usability as your first 4 procedures that you're using. And then how are you going to review and approve those without a document control procedure? How are you going to keep records without a record control procedure? How are you going to demonstrate the people that performed all these tasks were trained before they actually started performing these activities? So you need document control, record control, and training. So now we need 7 procedures before we even got into our first design review. Yes. So quality system requirements, yeah, you could probably delay a lot of the quality system until you've submitted your 510K, but those 7 you really can't afford to delay. And if you're going to be doing a clinical study, well, there's a few more things you're going to need as well. You're going to need CAPA, complaint, you're going to need a clinical procedure. There's a lot of things you need in the quality system, and you need to implement them earlier than you thought. Not to mention that if you're going after MDSAP, you might have a 6-month lead time trying to schedule a stage 1 audit. For summative usability testing, it is not just write a justification for why we don't need this, or find 3 users, do a bioskills lab, and you're done. That's not how it works. Pretty much any device with an electronic interface, a digital interface, is going to require more involved summative usability testing than you are prepared for. The FDA has this 2016 guidance on how to do usability testing or human factors testing, and they talk about doing an FMEA or doing a fault tree in there. But when you get the deficiency letter from the FDA, they want you to use a use-related risk analysis, and they don't want you to estimate the probability of occurrence of harm when you're doing use-related risks. They want you to assume that the risk will happen. So they're actually going against or contradicting exactly what's in their own guidance document. So you need to actually know exactly what the FDA is looking for now on the summative usability testing, not what's in the guidance from 2016. It's been 6 years. They've changed what they're looking for, and they haven't updated the guidance. And that may not be fair, but that's how things work at the FDA right now. So what do you need to do? You need to first identify what your user interface is. Identify what your user groups are, your patient population, your use environment. That's just definitions, and that's going to take you a few pages. Then you're going to have to do brainstorming to identify tasks. So what are your use-related tasks? Then you do a task analysis and then identify use errors. You would look at complaints. You could look at adverse events. You could look at competitor products. You could do formative testing. Then you're going to put this in a use-related risk analysis table, URRA, and one of the columns is going to identify which tasks are critical tasks. Well, you need to make sure you understand what the FDA views as a critical task and what their definition of it is, which is probably different from what the IEC 62366 standard says that you read. So you really need to know exactly what the FDA is looking for usability now. And last but not least, the customer says, oh, I got everything all done. We're ready to submit now. And they didn't listen to me the 400 times I said, you need to make sure you apply for the small business status. Otherwise, you're going to pay full price. And it takes 60 days to get that. I'm going to cover that one more time in this presentation. But every year on August 1st, you should be applying. You have to attach your tax return if you're a US company. If you have foreign subsidiaries or foreign parent company, or you're a foreign company, you're going to have to take your application. It's a slightly different form. You submit it to your national tax authority. They authenticate that this tax information is correct. They sign, date, stamp, and then you send it to the FDA. And it has to be an original that goes to the FDA. Can't email it either. So this is everything these are the 10 items. I went through those really fast. We've gone through this once before. We actually have a webinar, a blog just about this topic. You really need to make sure you do all these things as part of your plan. And so if you follow our planning template, you will have these things in there, but do not underestimate how much work this is. Okay, so now we're going to cover design planning. We actually have a template for this. It's template 21. It's a combined design plan and risk management plan. This is what the top of it looks like. It's draft 7 now. It's only 4 pages. You fill it in as you go. The revision history will be at the top, and you can add or delete one of these names. These are just functions of who's going to approve the plan. In general, I recommend whoever is the design team lead approves the plan, and then whoever the author of this document is. Hopefully the design team lead is delegating some things, so it's 2 people doing this. But I have 3 on here. You could have more, but be careful. The more people you have on here, you have to keep on having those same people review and approve every single time you revise. So the fewer people you start with, the fewer people you need to make edits as well. So if you fill in the form for subscribing to this webinar, instead of just watching the YouTube video, then you will get a copy of this design risk management plan template, and you will also get our table of contents. Here's what's in the phase 1. So we have 5 different phases in our design control procedure. If you want the whole entire design control procedure and all the templates, not just this free one, then you would have to purchase it. It's SYS 008. It's on our SOP page, and I'll put a link down below. But there are basically only 3 things, 3 bulleted items here for planning. You could use template 19, which is not listed here. It's listed in the next section. But if you want to do a separate document for user needs and a separate document for product requirements, it's template 22 and 23. If you have a software product, we have different templates for these documents as well. But you decide what template you want to do. But one of the requirements is you have user needs, and another one is you identify what product requirements there might be for this. Some people like to combine them both into one document. We've done that with template 19. And if you have something like software, you might have here's the user needs and here are the product requirements, or an SRS or something like that. The other documents are this template, the plan. Over here, as we go through each section, we're going to change it from target, so that's the target date for this, to the actual date. So as you go through each phase, after you complete it, you're going to update the template to indicate these were the actual dates that these occurred. And then we have a design review meeting minutes template that you fill in each time for a design review. You use the same template each time. It basically says these are the documents that were reviewed, these are the people attended, this was the date and time it occurred, and here are the action items that are remaining, and you highlight any things that should have been done that weren't finished that carry over into the next phase. Every single time you do a design review, we call this a phase gate review. If this seems like I'm going mind-blowing fast here, that's because you're supposed to be trained on design control, so that none of this should be new to you. If you don't get this already, that means you really need design control training, and you ought to be watching our video on design controls, and you ought to be purchasing our design control procedure. Otherwise, this is just showing you somebody that already knows design controls, how we document it in a very simple way in our design plan template. Next, we have the design inputs. So people are like, I'm not going to work on a plan. I'll do that later. I'll delay that. And then they say, oh, I'm not going to work on the inputs now. I'll delay that. I'll do that later. Don't do that. Get this stuff done early. These are the first things you're supposed to do in the design project. You need to do them early, and that'll become obvious why in a few minutes. But these are all the things we put in here. And you notice a whole bunch of stuff is redlined. That's because the FDA came out with this new guidance document that was specific to cybersecurity, and we have now all kinds of new cybersecurity documents. And you could say, well, I'm going to do them in the next phase, or I'm going to do them in an earlier phase, but you have to identify what your security design inputs are. And if you have any variables that you're going to enter into your software, you need to figure out what those boundaries are. What is the limits of that data entry? How big can it be? How small can it be? And that's actually a requirement. If you were doing, let's say you were making an insulin pump, the insulin pump receives information from a continuous glucose monitor. And if it gets information that doesn't make any sense, what is the pump supposed to do? Well, you actually have to design what it's supposed to do when it gets an error reading. Does it just stop functioning? Does it never work again? Does it give you an alarm? Does it give you some sort of warning that it's not getting accurate data from the continuous glucose monitor? What does it do? If it has a number that's really low, that differs radically from the previous measurement, and it looks like it's an error, there's no way somebody's blood glucose could have changed that quick. What does it do? That's boundary analysis. But you have to specify what your boundary limits are for each variable that it's being inputted into that, that pump. So that these are just examples of one test that you have to do. Cybersecurity hazard analysis and threat modeling. If you don't know how to do that, take a look at our cybersecurity webinar that we did on, and we actually have a work instruction specifically for cybersecurity. And then the other thing we did is we added a lot more information in here on human factors. I had just described the things that you need to do as inputs, defining your human factors. These are the 4 things I listed. In addition to that, you're going to identify the potential use errors, do a URA, at least start it. So what I've basically done is I've taken our original design plan template and I've added recent things to it as a red line so you can see, hey, this is what's new. Now we're into phase 3. Now, one of the things that I'm going to cover very shortly is when do you do a pre-sub? Right now, you just approved this page, your design inputs. You came up with all your design inputs, you put them in Form 19, which is our design and risk management traceability matrix. You've filled in the columns up to design inputs. You've approved them in your design review. Now is the time that you should be scheduling a pre-sub. So you should be preparing that pre-sub. Why do you do it then? Well, now you've identified what your testing plan is. That's right here, the testing plan. So all the tests that you're going to perform for safety and performance of your medical device, you've got that plan now. You've also got, you've already started your use-related risk analysis or usability. You started your software, you started security. You've done a lot of things already. Now is the time for you to ask the FDA questions. If you haven't done these things, you're jumping the gun. You're not ready to ask for a pre-sub. And if you wait until you've finished your design and then go back and fill these in later, you won't know what questions to ask the FDA. And you will have designed a device that can't pass some of the tests because you didn't have them in mind when you were designing it. You need to know what tests you're going to pass in order to design the device properly. So don't skip steps here. You need to do this before you do a pre-sub, and you need to do it before you start speccing out your device. Now we have the design freeze. This is the design and development phase. You can see I've added some more things. New requirement for cybersecurity, a software bill of materials. I get all the way to the final stage where within a couple of weeks of submitting to the FDA, and I ask the client, well, what is your off-the-shelf software? Well, they can't tell me. Well, that's a requirement that should have been back here during phase 3, not after stage 4 when you're getting ready to submit. And how can you even validate your software if you don't know what software you put in it as an off-the-shelf software? What operating system did you use? What library did you use? Well, I don't know. That's not the right answer. You also need that software bill of materials. That's a new cybersecurity requirement. You should be doing a critical task analysis. That's part of your usability testing. So all the draft labeling and draft construction reviews, including cybersecurity labeling. So all these things, these are new requirements And yes, we have design outputs. That's your drawings and specifications. We have your risk analysis. We have your software design spec. We have all your verification protocols and validation protocols before you actually do them. Yes, they're supposed to be reviewed and approved prospectively before you actually conduct them, not afterwards, and then you adjust the protocol to match the results. That's not how it works. The FDA actually checks the dates, make sure you approved it before you actually conducted it. So design freeze. Why do we call it a freeze? Because it doesn't make sense to make changes to the design after you started testing, because it costs a lot of money. If you're spending $100,000 on testing, you don't want to have to repeat that $100,000 of testing just because you made a change. Get your design frozen. Do not make a change from that point forward. So at the end of this phase, it's called the design freeze, and that's when you have your phase 3 review. Now we begin our V&V testing. The first V is verification. The second V is validation. Be careful, because there are a lot of things like process validation and software validation that include the word validation, but they aren't actually validation activities. They're verification activities. And because they both occur around the same time, after your design freeze, before your 510K submission, it's very easy for companies to get confused between these things. But examples, basically all the testing that you're going to do, except maybe section 18, 19, 20, could be verification testing. The testing begins with section 14, sterilization and shelf life. Those are verification tests. Making sure the product is sterile, making sure it can hit the 5-year shelf life that you wanted. Those are verification tests. Next, we have biocompatibility. That would be verification tests, making sure the materials you selected in the manufacturing process do not create a product that's unsafe to touch humans or inside the body. Next, we have software validation. We call it validation, but it's really verification, making sure that all your software will meet the SRS requirements, software requirement specs. That would include unit testing, integration testing, and then system testing. Next, we would have the electrical safety and EMC testing. This is verifying the device meets the requirements for electrical safety and electromagnetic compatibility. And there might be other tests that are particular to your device, like electrode testing, if you have a TENS device. Next, we have section 18. So we've gone through 14, 15, 16, 17. Now we're to section 18. That's benchtop performance testing. This could be both verification and validation. Animal testing could be both. Cadaver testing could be simulated use validation testing, and then clinical studies are validation. So it's 18, 19, and 20 is when you get into the validation testing. You'll notice in here, I've added a whole bunch of things in red. Those are all cybersecurity things that get added to section 16. So there's a bunch of testing that needs to be done by a qualified third party that's independent of your company, and they're going to need to make sure that they show their qualifications, show their independence, and show that your device is secure from any software hacking or penetration by some outside party, or the clinical data from your patient isn't available to somebody and they can't monkey around with it. But at the same time, you also need to come up with a post-market surveillance plan that indicates how often you're going to retest for cybersecurity, because hackers don't stop once you've gotten your 510K. They're going to keep on trying to hack into a system. You need to make sure you continue to come up with new testing methods and keep on trying to break your software so you can fix your software. And so you have to identify some sort of a plan for retesting for security of your software. Now, this is the final phase. After we've done the V&V testing, now it's time to actually submit to the FDA. These first 4 items could be in the previous phase, because after you've done all your software testing, you're going to fill in these 2 documents. You could create them in phase 5, or you could instead say, no, we're going to put them in phase 4 because we want to submit to the FDA as soon as we finish all our V&V testing. If that's the case, you're going to need this software overview because it's 4 or 510K, and you're going to need the traceability analysis. They want that software traceability in the 510K as well. It's one of those 11 documents that are listed here. If you do animal studies, sometimes we're doing animal studies before a clinical study. And if that's the case, then you might be saying, well, we're going to use this as safety testing, and we're not done yet, and we're not ready to submit a 510K yet, or we're not ready to submit for CE marking yet. Depending on when you need that animal study data, that could be after your 510K, it could be before your 510K. It depends on what the purpose of the animal study is for, but normally it would be prior to a 510K. And the same thing for the human clinical validation. If it's needed for the 510K, you would want it probably in phase 4. If you need it for CE marking only, then probably phase 5. The risk management report, that you don't need for a 510K typically. You typically only need that for CE marking, so that would be something you would normally do during, say, phase 5. The regulatory approval, you're waiting for that. So during phase 5, the FDA makes their final decision on your 510K, and you get the 3 letters from the FDA. One is your form letter giving you clearance, one is a copy of your 510K summary, and the last one is your indication for use, form 3881. Those 3 documents are, when you get that email with those 3 documents, now that's your clearance. Design transfer checklist. So as you are taking your product from, we've done our V&V testing, to we're going to commercialize, you need to ramp up all your manufacturing, do all your process validation, write your procedures, train people, validate all your equipment. That's all part of your design transfer checklist. It's not something you do in a day. It's something that will probably take you months, and you ideally get it done while the 510K is being reviewed, but sometimes you have to start earlier to finish it in time. The process validation is part of that design transfer. And then you want to also come up with a post-market surveillance plan that includes risk management activities that you're going to conduct after the release of your product. That would include verifying use errors. Are there any new use errors that we hadn't anticipated? Are the risk controls that we put in place for usability preventing some of the use errors that we anticipated? That would be an example of what's in there. It's also the largest section that would be in a CE marking submission. Now, we've talked a lot about project management. We've talked about the different phases. Now I'm going to show you where people kind of make mistakes here because they really haven't thought about, they really haven't thought about how long things take. And I think I might be blocking part of the screen here, so I'll move that. So for 510K project management, we use a software tool called Asana. Asana has a free version and they have a paid version. In the paid version, you get this timeline view that I'm showing here. If you get the free version, you don't get that. But what the timeline allows you to do is to move these things around. You can actually click on this box and move it. But let's take the typical client here. That's what I was trying to represent with this example. The client says, well, I want to have my 510 clearance by the end of the year. So we've done everything we can to try to compress their schedule. They're talking to us right now because it's almost June. It'll be June this week. And the client's saying, well, we want to have this 510K clearance by the end of the year. That's not possible. It's not going to happen. You're already late. It's not going to happen. Sorry. If that's your plan, get it done by the end of 2022, and you haven't done a pre-sub yet, you're out of luck. It's not going to happen. Here's why. First of all, the FDA review, that's going to be at best 4 months long. You thought it was 90 days? Well, the FDA is going to identify some deficiencies, and you're going to take a few weeks to respond, maybe a month. That's going to add a month to your schedule. Average is 120 days. There are a lot of companies that have to do retesting. Hopefully you don't have to do retesting because you did a pre-sub, but if you have to do retesting, you could be looking at, this is going to be more like 9 months instead of 4 months. So that's, we said we're going to start this around, we're going to submit this to the FDA just around Thanksgiving. So it's going to take all of December, all of January, all of February, and sometime in March, you will get your 510K clearance. That's best case scenario. Now we're going to work backwards from the end in mind. The end in mind, we're going to submit it Thanksgiving, best case scenario. Well, what is the last test report that I'm always waiting for? It's either sterilization validation, biocompatibility testing or electrical safety. Well, this particular example I'm using here is a non-sterile product, so we don't have any sterilization validation. And we're going to go one step further. We're going to also say, well, this device doesn't have any biocompatibility requirements either, because it's non-patient contact. Maybe it's a electrical hardware. It's going to be some sort of a reader, like a blood glucose meter. But you still need to do electrical safety on this device. And before you do the electrical safety, you should always do the EMC testing, because if you have to make changes to pass the EMC testing, that means you're going to have to redo any electrical safety you already did. So do the 4 weeks of EMC testing first, and then do the 8 weeks of electrical safety testing, 12 weeks. So working backwards from the last report, our electrical safety report, we need to start that EMC testing back in sometime in August. If I request a pre-sub now, I'm actually not going to get the 60 to 75 days that the FDA says is their target. Let's say I submit it June 1st. I'm not going to get my meeting in August. I'm going to get my meeting in September, because the FDA is backlogged from COVID. So I'm going to get a September meeting, but I need to start my electrical safety or EMC testing in August. So there's no way this is going to work. I'm going to have to do it at risk. I'm going to have to start EMC testing. I know I need to do the EMC testing, but I'm not going to be able to ask any questions about that testing, because I will have already started it by the time we have our pre-sub. So most of my questions in that pre-sub meeting are going to have to do with our benchtop performance testing, which I'm optimistically saying is only going to take a month, but it probably will take much longer. And if this were actually a blood glucose reader that we were doing this project for, there's a 350 person usability study that I have to do. That might take me a little time to recruit for. So this benchtop performance is just one test. If I have to do usability testing for that kind of device, I might need more time on here, and I might need to actually start that back here right after the pre-sub meeting, maybe in September sometime, and I'll be lucky to get that done by Thanksgiving. Before you submit anything to the electrical safety lab, so let's say electrical safety starts in September, before that, your risk management file has to be done and your software validation has to be done. Both of those are inputs into your electrical safety. They'll actually give you an 80-page document, ask you to cross-reference where can these things be found in your risk management file. If you don't have a risk management file yet, you're doomed. So this, I put down here a month, but probably it takes longer than that. But fortunately, I don't have the electrical safety beginning until September, so I could do it in July and August, both before our pre-sub meeting. Software validation needs to be done before our pre-sub meeting. If I have any cybersecurity questions, I could potentially work on those while I'm working on my, while in parallel with this EMC and electrical safety. But if I have to make massive changes to it, that might affect actually some of the documentation. The FDA says, well, what version of software did you use for the electrical safety? Which version of the software did you use for the usability testing? Which version of the software did you use for your benchtop testing? So some of these things might be done on the old version of the software. If I make changes due to cybersecurity, I may have to redo some testing. Remember, when we start the V&V testing is supposed to be when we have a freeze, we don't make any more changes. So where are we saying the design freeze is? Normally we'd have it after our pre-sub meeting before our testing, but we're actually doing software validation, EMC testing before our freeze, just to meet your Thanksgiving submission deadline. This schedule is too compressed. You're not giving yourself a chance to have a design freeze. You're having to meet this artificial deadline of Thanksgiving submission. We're having to push things back into the development phase for testing before they've really been finalized. So that's where we end up with all these problems. So you definitely need a project management tool. You need to identify what's a critical path item, what things need to be moved around, which things are dependent, all that needs to be defined. If you're working with an outside vendor, you could use Asana to communicate tasks with them, but you probably wouldn't want to do it with a paid version. You'd want to do it with a free version, and you would just boil down one of these tasks into its own project. So here's the risk management file. That's a project. Here's one for process validation. Here's one for molding. Whatever the task is you're doing with the outside vendor, you're going to have that as a project in Asana, but use the free version. And then you're going to put those tasks in here as steps into this overarching design plan that has the timeline. So let me stop sharing this, and instead I will share my Asana document. This is the right one. Yes. So here's an actual Asana file. And like I said, I can move things around like that. And I can also, all these dependencies, the way I created those, it allows me to just add a dependency. So I can just click over here and plus and add a new dependency, or one that I don't want to be dependent, I can delete it and see that line went away. If you want to create a free project to share with a vendor, the way you do it is you go up here to your account icon here, and you go down here to more, right below in admin console, and create new workspace. And now I can create the name of the project or the team that we're working on, and I can list all the members by email, and it creates a new workspace. And now I'll have an Asana project platform that I can use with each of my vendors. What I won't be able to do though is this timeline. That's one of the premium features that's on the paid version, but I'll still be able to have the list view. Here's the list view of a project. Here's the board view for those of you that like Trello. The Asana does the same thing. And then the timeline view on the paid version. And then you also have a calendar view, so you can see what's going on this week, what's going on this month. You can change the settings for it. You can also see an overview of your project, so you can see who's on the team. You can even put a project brief in there. You could attach files, so the project plan as it's updated as the software requirements and all the software documents, all your hardware documents, all your design planning documents, usability documents, whatever documents you have for that project or that phase of the project, you can put in here and attach and share with everybody. You can identify milestones. So this has a lot of functionality, and it's available also on my mobile device. So I can see it on my phone. I can see it on my tablet. I can see it on any desktop. I don't have to have it installed in my computer. It's a browser-based tool. So that's what we use actually for project management, and you might want to try it as well. Now we're going to go back, and we're going to go back to our slide presentation. Okay, and the next slide. Okay, so for those of you that are going to request a pre-sub, I have mentioned the FDA is taking longer. This is the exact wording we put in our proposals here. I think the template actually in our proposal says 3, but we've actually had 4 now pre-subs where the FDA rejected them. We already know that they're rejecting them for anything that's involving infection control, anything that's an IVD, but we've actually had it for 4 other submissions that weren't in those groups. The FDA refused it. So if your company is trying to submit a 510K pre-sub or a de novo pre-sub, anticipate that they're not going to hit the 60 to 75 day timeline, and they're going to be more like 4 months. Some of them have taken us 5 months. Which brings me to one of my points I wanted to make about project management of any project, but 510Ks in particular. When a company says, well, let's estimate how long this will take. Oh, we'll say it's going to take 4 weeks. Test that. Go get a quote from 1 or more vendors that says they can actually deliver in 4 weeks. Look at what the timeline was to complete that same task in the last 510K project you worked on, if you've done a 510K project before. Here's an example. I worked with a company that had been around for a very long time. When I say a very long time, decades. I was the director of quality and regulatory affairs for the company, and I was looking at a design review meeting. So we were having one of the design reviews probably right around the design freeze So I've been asking, do you want me to look at these documents ahead of time? Do you want any help? Do you have a preliminary meeting? Any question? No, no, no. We don't need you yet. We're going to wait until the design freeze. Okay. So they invite me to the design freeze, and the first thing I see in the table in the Gantt chart is they're going to complete ordering a mold and having it delivered for molding plastic parts in 4 weeks. And this particular part was a mold for a housing for a multi-parameter monitor. I'm like, that's 12 weeks. They're like, what do you mean? That takes 12 weeks. Somebody can't actually, I mean, if they dropped everything and the whole entire shop worked on it, maybe they could do it in 4 weeks. But you're never going to find somebody that can actually deliver that mold finished and working in 4 weeks. It's 12 weeks. The actual time ended up being more like 14 weeks in reality. But they had said, oh, this is going to be done in 4 weeks. And I said, not only did you wait to involve me when I could have given you that information, but the person that actually is going to be buying the product isn't even invited to this meeting. So the buyer, our supply chain manager isn't in this meeting, doesn't know that you need it. And you expect him to deliver it in 4 weeks, but he doesn't even know about it. Why didn't you invite him to the meeting? Silence. Okay. Just as an aside, I used to run a molding facility at multiple companies. I've designed molds. I've run molds. I do write the validation protocols. I know what I'm talking about. It's not going to be 4 weeks for this really big mold for this really big plastic part. And of course, they want it to look perfect because it's cosmetic. It's the outside housing of the unit on a brand new flagship product. It's not going to happen. So their whole entire project was completely busted by 8 weeks, 2 months, right off the bat, just because of the mold. And there were so many other problems with it. So make sure whatever is in your timeline, check each item. Is that real? Is that estimated time that we put down there real? FDA says 60 to 75 days. We find that's really 4 to 5 months. Totally different. Next. What should you include in your pre-sub? So a lot of people, they're like, well, what do we need for the pre-sub? Well, I say, I need a minimum, a device description. That's number one. And I would also like labeling, instruction for use in a label. Well, they balk at the label because they haven't created one yet. I'm like, technically, the label isn't required. Technically, the instruction for use isn't required. But I know that if you don't already have one, and we're doing a pre-sub now, we're going to have problems later with you still not having it ready. So I'm asking for it now, even though it's not required. Start working on it now. I give them my template for a device description. They have trouble filling information in the device description. They don't even know what all the specs are yet. Well, that's why we're doing a pre-sub. We're figuring out what testing we need to do so we can fine-tune those specs. It's okay to have a spec that's preliminary and change it. The pre-sub doesn't have to be the final specs. It's a pre-sub, not an actual submission. So you're allowed to make changes. But there are certain tests that are not defined in the standard. So we may say, oh, biocompatibility, got to do these tests. But you might have questions about your biocompatibility. There might be certain materials that aren't compatible with certain tests. Your material might actually be cytotoxic. If it's aluminum, aluminum's not a problem from a biocompatibility standpoint if it's touching your skin only, but it won't pass cytotoxicity. So don't even bother testing it. A lot of people don't know that. There are a lot of cytotoxic materials out there that will fail your cytotoxicity testing, but are biocompatible, and don't even bother wasting the time testing if it's going to fail anyway. You need to identify what your level of concern is for your software. And in the new software guidance that was released as a draft back in November, I believe, of 2021, they were going to change it from level of concern being minor, moderate, and major to being basic documentation required versus enhanced documentation. So we may have that change coming down the road as well. So you might not want to just ask about level of concern. You might also want to ask, is this basic or enhanced documentation if that new guidance takes effect? You might want to ask questions about specific clauses that you think are not applicable or deviations because you can't perform that test for your device. For some reason, your device doesn't have those features and it wouldn't be applicable. Those would be great questions to ask the FDA during a pre-sub. Your usability testing, you're going to design your summative protocol. You might want to share that with the FDA along with your critical tasks. Identify what your user groups are, your use environment, describe what testing you're going to do, make sure the FDA is okay with that. If you're going to do it outside the US, which the FDA normally doesn't say yes to, you definitely want to ask them those questions during the pre-sub meeting. They can't give you feedback on animal testing unless you give them an animal study protocol, and it needs to be GLPs if it's an animal study. Your benchtop testing, what is your statistical analysis? People ask me, well, how do I do that? Well, you need an actual statistician to help you with that if you don't know. You can't just ask the FDA, how many should I do? Well, 300 sounds good. That's not the answer you want. What you want to do is propose a statistical rationale, put that in your protocol, and have the FDA give you feedback on it. What is your worst case scenario sample? What is the worst case for a cleaning validation? What is your worst case for whatever the test is going to be, biocompatibilities, sterilization, shelf life? What is the worst case scenario? Those are the ones that you should be specifying in your protocol and provide a rationale for. Here's just a little screen capture of the template that we use for creating a testing plan, but we have it broken down in a section. We list all the guidance documents and the international standards. And then for your specific product, we're going to add additional standards that are applicable to your device. We're going to take out things that are not applicable, and this will go from green as a draft to black, and we may even have some additional requirements that the FDA has identified below the table. So that's what our testing plan will look like. But normally we share this testing plan as a draft with the FDA in a pre-sub. One of the questions you should be asking in a pre-sub is, are there any guidance documents that we forgot to include? That might be something you want to think about. You might also want to go through the FDA eSTAR and look at what questions they're asking in there. If there's anything you're not sure about, that might be a question you want to ask the FDA as well. For those of you that aren't familiar with FDA eSTARs, that's a new template that the FDA has implemented. You're still allowed to use your original templates and do an eCopy, but by the end of this year, pretty much everybody's going to be switching over to eSTARs because the FDA will have its final guidance document on eSTARs, and there will be a brand new portal for eSTARs. Okay, now we've kind of covered what we should up to the point where you would have your pre-sub done and your verification validation testing is ready to begin. This is design freeze time. You've talked about all your testing protocols. You've gotten those all approved. You've gotten all your vendors in line. You've done all your prototyping. You're ready to start that V&V testing that's so critical. Now you're going to be on a tight timeline. This is the point where we're going to switch to, we're going to start using our 510K table of contents to manage the project, as well as our bigger overall design plan. If you found the first part of this helpful, please don't forget to like and share this with other people. And just as a little aside, for those of you that aren't familiar with all the features of sharing a YouTube video, I assume you're watching this on YouTube. And down here at the bottom, when you click on share on a video, it'll pop this up, and there's a little checkbox down here. If you check on that checkbox, whatever point you were in the video on, it will allow you to share the person linking to that exact spot in the video. So you can have somebody jump to that spot. So if there's a specific part of this video you want somebody to watch, you could share with them that specific time point. They can go back, they can go forward, but if you want them to jump to that spot right away, this is how you do it. So I thought that would be helpful to people. And if you've been watching this far, I'm assuming you're getting something out of this. Now, we have entered the phase where we are actually going to start preparing the 510K. So if you are one of our clients, Up until this point, we should have been working on your project probably on an hourly basis, and we were focusing on the pre-sub and your V&V testing, helping you implement your quality system, helping you with any kind of supplier issues. But now you've had your design freeze and you've started your V&V testing. This is the point at which we should start using our table of contents to manage the project and preparing the 510K. We normally ask clients to have weekly meetings with us, a reoccurring meeting. You don't want to skip those meetings because now you only have 12 weeks till you're going to launch your, before you're going to submit your 510K. The EMC testing is 4 weeks. Electrical safety is 8 weeks. That's 12 weeks. Biocompatibility could be 10 to 12 weeks. Sterilization validation could be a little bit longer than 12 weeks, but all these are roughly about 12 weeks in length. So we have 12 sections that we have to prepare in addition to the testing section. So it's 20 sections to a 510K. Section 13 is labeling. Sections 14 through 20 are testing. But the boilerplate stuff that comes in the beginning of a 510K submission, those 12 sections, we should be completing one a week at least. And you should be having weekly meetings with us, and do not skip them. Otherwise, your 510K project will be delayed. Remember, I said you need to apply for small business status. If you are one of the many clients of mine that has not listened to, you need to apply for small business status. You didn't apply on August 1st for the new fiscal year, which begins October 1st. Now is the time. We are in the 12-week countdown to submission. It takes 8 weeks to get your small business status approved. If there's any problems they have questions about, that's going to cause a delay. Request this now. This will take you at least 60 days. And if you don't need this $9,000 difference here, I'd be happy to take a tip off your hands. But my recommendation, fill out the form, submit it to the FDA, and get your small business status. This is our table of contents. Old version, new version. What is the difference? Mary Vonner suggested that we add a column over here to make it easier to write these notes. I like that a lot. She actually puts the name of the person that's supposed to do it. Well, I write client here. Sometimes I indicate that it's something that we need to do, or I'll just say it's in progress. Other times I'll say we're waiting for the client. Mary actually puts the name of the person over here and puts these kind of notes. Whichever way you do it is fine, but adding this extra column, we switched from being the portrait view to being a landscape view. The other difference here, you'll notice we have some things that say no longer required eSTAR. When we were doing our traditional submissions, we had different sections separated, and there were certain things that were required because we weren't using an eSTAR. For example, we needed a table of contents. So this document would actually be submitted to the FDA. When we switch over to the eSTAR automatically has everything in a set order. You have to attach it in that order because it's a PDF form you're filling in. The FDA's already established what the contents is going to be by giving you a template. You have to do it in that format. So we don't need a table of contents anymore. So that just goes away. We just use it as a planning tool only. We don't have it as part of the submission anymore with the eSTAR. And we actually used it as part of the submission because it was an RTA checklist item for the eCopies. So if we're doing an eCopy, we use this. If we're doing an eSTAR, we use this. And pretty much everybody on our team is doing eSTARs now. It takes a little longer, but we don't have any RTA holds. Another item on here that's no longer required, this form 3514. Instead, we're using the eSTAR. It has all the same information and more. Another item, this comparison of indication for use. We don't really need that anymore. They're already asking us to compare that in the actual eSTAR, so we don't need to include that. We just fill in the form 3881, which is embedded in the eSTAR as well. This class 3 summary, there are no more class 3 devices, so you don't really need that section. We were indicating it's not applicable over here, but on the eSTARs, it's not even a question. There's not even a place to put it. So there's been a lot of improvements with the eSTAR. It takes longer to fill out. We're actually charging more now for our submissions. We were charging $14,410. Now we're at $17,500. So $17,500 for doing a 510K. Why? because it's taking us an extra day, just an entire day, to fill out these eSTAR templates. And the new cybersecurity requirements are taking longer. We're also very, very busy. So one of the things we do to keep from getting overloaded, raise our prices a little bit. So if you were wondering why our prices have changed, it's eSTAR. You can blame that, but it's actually helping out a lot of our clients. We had one of our clients get their 510K clearance in 52 days. So the eSTAR is definitely worth your time and money to use that format instead of the old eCopies. Are there any previous submissions? So this is something a lot of clients, they will have already done a pre-sub and then they'll start hunting for somebody to help them with their 510K. If that is your company, make sure you share those pre-submission meeting minutes with us so we can reference it in the submission. That's a requirement. And then any concerns that the FDA made during the pre-submission meeting, in their email response or during the actual meeting, if you had a teleconference, we need to address those in a response letter that you attach to your eSTAR or your eCopy. It is important in every single test report. And I mean, all test reports, do not forget these things. Number one, you need a sample description. Almost all the companies out there, they don't spend enough time writing what's going to be your sample description. I recommend when you submit your samples to a testing lab to do the testing, give them the wording and any pictures that you want them to include for the sample description. Why? Because then that information will be very clear as the FDA wants it, and it will be consistent across all your testing reports. Here's the justification for why we chose this one, and here's the write-up of it, and here's a picture of it. Please insert this in the test report. You're helping the lab. If they have a problem with it, they'll discuss it with you. But the problem I run into is they didn't put in any justification for sample size. They didn't put any picture of what was used for the samples. They didn't write down the lot information sometimes. They didn't identify what is the worst case scenario for the samples. All that information is left out. Do not do that. Clarify the number of samples and lots, yes. And also, what is the rationale for your sample size? Is it in the standard, you shall use 10, or is it some other reason that you chose that number? And this applies to all the section 14 through 20 of your submission. What if a section is not applicable? So any one of those sections might not be applicable. You don't have a sterile product. You don't have a device that has a shelf life. It's not time-dependent aged. Well, then section 14 isn't applicable. If the device doesn't come in patient contact like IVDs, section 15 isn't applicable. If your device doesn't have software, like a catheter doesn't have software, section 16 isn't applicable. If you don't do any animal testing, section 19 isn't applicable. And 20 is often not applicable for a 510K. Maybe only in 10 to 15% of them do you actually have some clinical data. So you just say not applicable, provide the rationale, whether it's an eCopy or an eSTAR. eCopy, we have a standard form. We just write the sentence explaining why that section is not applicable. eSTAR, we just fill in the form and say why it's not applicable for that section, or click the radio button, or both. At the very end of the process, when the 510K is cleared, you're going to get these 3 letters. A substantial equivalence letter. It's a form letter that has your company contact information and a couple of details about the device, like the name of it and the regulation. It indicates here's when you submit it, and now it's cleared. The indication for use form, form 3881, and finally the 510K summary. You are not required to do a 510K summary. It is always revised by the FDA. They always ask us to make changes on the 510K summary. If you don't want to deal with all those changes, you can do a 510K statement. Whether it's an eCopy or an eSTAR, you can still do a 510K statement. The trade-off you're making is now you're agreeing that if somebody requests a copy of your 510K, you will give them a redacted copy within 30 days, and you have to do the redaction, not the FDA. So if that's something you want to do, then you can do a 510K statement. It saves us some time. So a lot of our clients, they say, no, I don't want to have to provide a redacted copy, and they go for the 510K summary. And then they complain about the things the FDA is asking them to include in the 510K summary. So If you want to avoid them, you're really sensitive about controlling your confidential information. By doing a 510K statement, you control what's redacted, what's not, instead of having the FDA do it. So I would highly recommend considering doing a 510K statement instead of a 510K summary. For the 510K substantial equivalence comparison, when your company is trying to decide what is your predicate, everybody spends way too much time on trying to pick a predicate that has the exact same technological characteristics. That's not the most important thing. The most important thing is the indication for use are the same as your device. In fact, the FDA often wants it to be identical. But the 6 questions they're looking for, question 1 is the predicate a legally marketed device? If you pick a device that was removed from the market because of a recall, that's not legally marketed. It is possible that somebody was granted a 510K and then went out of business, and you could use that, but you need to talk to the FDA about it in a pre-sub. Next, do the device, the predicate device and your device have the equivalent indication for use? Replace the word equivalent with identical, because any differences are going to be hard for you to convince the FDA of. It's not impossible, but it's very hard. So try to make your indications identical. The next item is the technological characteristics. They have very specific things they consider to be technological differences, such as power supply, materials, mechanical performance. So there are different things that they're looking for. Are they the same technology or not? If they're not, then you're going to have to go over here to the next question. So they say, in this item, do the differences introduce new issues of risk? If your device is electrical and the other device that's the predicate is mechanical and not electrical, those are different. So it's not substantial equivalent. Most IVD products, your device and their device, same technological characteristics, but theirs has a different indication for use. That fails at this question. But if you have both the same indication for use and yours is an ELISA test and theirs is a flow-through assay, 2 different technologies. So they're different issues of risk, so not substantial equivalence. That's why IVD tests have so many different product codes, because they are different types of tests for the same indication. Then we have are the methods. So if you identify there are different methods, but they don't create new issues of risk, then how did you validate that? That's this next question. And then does your data support the substantial equivalence? Those are the 6 questions for the substantial equivalence process. And you'll actually see a reviewer like circle the yeses. Yes, yes, no. And then they'll go down here, no, and then yes, and substantial equivalence. So they'll actually circle it so you can see their decision-making process. Third-party reviewers do that as well, which brings us to the third-party review question. So if you are thinking about a third-party review, I will show you how to do this very quickly here. We're going to share. We'll go to this page here. And we will pull up the FDA website. So this is just all the databases. And I'll just put in a code here. Let's see, QFB. I don't even know what QFB is. Okay, so I happen to pick a ventilation device, and it's not third-party eligible. So when you see this down here, you can't submit it to a third-party reviewer. The third-party reviewer, you're submitting it to them instead of the FDA, and they will do an expedited review, and they will charge you more money for it. So you pay them, you submit to them, they make a decision, they recommend it to the FDA, they upload it to the FDA does a final quick check in 30 days, and you get your 510K in 45 days instead of 90 days. So it's essentially cutting your time for review in half, but it costs more money, and it's not for all devices. This one, it's not eligible for. What devices have we done this a lot for? In the last 2 years, been a lot of mask submissions. So FXX is the code, surgical mask down here. These are the third-party reviewers you can choose. The only one we recommend is this one right here, Regulatory Technology Services. Prithal Baum is the person that's our contact there. There's her email. That's the address. That's her phone number. That's who we work with. We don't work with the other ones. Why don't we work with them? Because every single one of them has not had enough experience to warrant it. Why do I say this? If I go to this company's website, right at the top of the page, it says, the RTS engineers, scientists, and clinicians have reviewed over 1,500 submissions over the last 18 years. This is their average review time for the initial review. And they actually list submissions down here, and some of them that we've worked on are listed right at the top here. So we've already passed 3 of them that we've done. So we work with this company a lot. We highly recommend them. I have used other ones. I do not recommend them. And RTS in particular has a lot of experience with software and AI devices. So if you have those types of devices, that's a lot of what we do. And we like working with RTS because they have that experience as well. Other vendors, absolute disaster if you try to take software to them. So that's the third-party review process. We'll go back to sharing my presentation. Make sure you choose the right third-party reviewer, only RTS that we recommend, and format your submission. So one of the things that they require, they will accept an eSTAR. So we have submitted them an eSTAR and they're okay with that. There's not really an advantage to doing the eSTAR with RTS because the RTA hold process and resetting the clock, none of that really applies because you're already on an expedited review timeline. But if you plan on using that same submission information later for a subsequent submission to the FDA, that could be a reason why you want to put it in an eSTAR. Maybe that you just want to put it in the eSTAR to make sure that you haven't forgotten anything. But if you're doing an eCopy, you will have to actually fill out an RTA checklist, and you'll have to include that in your submission. And instead of having the user fee paid to the FDA, instead you're paying RTS directly, and you have to have confirmation that they've received that money. But these are some of the guidelines on working with a third-party reviewer. And I am not showing my slide properly. Sorry about that. Okay, now eSTAR is coming, and we already have the templates, but we still are technically creating an eCopy because we have to load the eSTAR, which is one file, a PDF, onto a flash drive. This was all submitted in a particular day. We had a traditional 510K, we had a special 510K, and we had a de novo with a second flash drive that had statistics and miscellaneous data on a separate flash drive because it was so big. It was all the clinical data. So this was 3 submissions in one day. It was probably the last day of September, probably about 3 years ago, maybe 4 years ago. If everything goes as planned, we've been told by the 2 people that are creating the eSTAR template that the portal for uploading eSTARs will be available by the end of the year. And so this eCopy validation module will no longer be needed, and we won't need these flash drives anymore, and we'll be uploading eSTARs to the FDA website, and that'll be by the end of the year. So all that's really changing for us is instead of putting it on a flash drive, we upload it to an account in the cloud. But for those of you that haven't used an eSTAR yet, you have quite a steep learning curve. There are some nuances to it, and they do take a lot longer to fill in. We also, the new guidance documents for cybersecurity, none of that's in the new eSTAR either. So you would have to actually have templates for that like we do, and you have to attach it to the software section under cybersecurity. Okay, now milestones. We actually have on our 510K proposals, we actually identify milestones that people pay us at. There are 4 milestones. One of them is the kickoff to the project. The second one is halfway through the testing. We estimate the testing should take 12 weeks. So halfway through should be 6 weeks. It could be shorter, it could be longer, but we try to stick it to halfway through the testing. That's when we're going to submit the second invoice. And then the third invoice is when we actually submit the 510K, typically about 12 weeks out. And then when we receive an AI request, because we use eSTARs, we don't have an RTA hold. And so the next milestone after you've submitted the 510K is 60 days in. So at 20 weeks of the project, 6 weeks after this 12 weeks, I'm sorry, 8 weeks after this 12 weeks, so 20 weeks, that's when we get an additional information request from the FDA or deficiency list. It doesn't always happen. We actually had our second submission ever come through with no AI requests, but that's a very, very rare. We're talking less than 1% of submissions will have no AI request. So don't count on that. Count on the 99% you will get an AI request with the list of deficiencies. The question is, will you have 4 deficiencies, which we've had, or will you have 48 deficiency, which we've also had? In both of those, the 4 and the 48, both of them got cleared. So it just because you have deficiencies doesn't mean you're not getting cleared. It just means you have work to do and provide the FDA within 180 days. And then the last milestone, we don't send you a bill for this, but that's when you can celebrate because you got your 510K clearance. Approximately 8 weeks later, because it took you maybe 3-4 weeks to provide the AI response, and then another 30 days for the FDA to review it, which is 8 weeks after this. So 28 weeks from kickoff to this. We don't necessarily have to have weekly meetings once you've submitted the 510K, but this gives you your timeline. I hope that's helpful to people that are wondering how long does it take. Okay, so now that we've finished the presentation, if you have any comments about this, any questions, please leave them in comments below the YouTube video or schedule a call with me or send me an email, and the contact information is here. I hope that was helpful to everybody, and I'm looking forward to what people think of this, and I'm going to try to share this with all our new clients so they remember those things at the beginning before we actually start the V&V testing, before we start that 12 weeks of testing. These are all the things they need to work on, and it's really important you don't miss one of those things, or we will have delays throughout the entire project. Thank you, everybody. Have a great day.